Hello friends, so today we are going to discuss about one of the most challenging and difficult aspects of orthopedic hip examination, but which when once understood becomes extremely interesting, intriguing and exciting. So that is what we are going to do today. We are going to understand the concept of coronal plane hip deformities. So what our plan for today is we are going to understand the adduction, abduction deformities. We are going to understand fixed deformities and deformities with free movements. We are going to understand the compensation by the body in form of the ASIS, anterior superior iliac spine, going upwards and downwards, the pelvic tilt. We are going to understand the apparent lengthening and shortening of the lower limbs. We are going to understand the Perkins method for quantifying the abduction and adduction deformities, and at the end we are going to understand the scoliotic compensation along with the trunk for the coronal plane deformities. So without further ado, let us begin with the concept of coronal plane deformities. Okay, so this is the model which I have made for reference purpose, for a schematic purpose. Okay, so consider this as the spine. Okay, along with this, here is the trunk. Okay, this is the pelvis. Okay, and both the black part are the anterior superior iliac spine. This is the right side, this is the left side. Okay, and these are both the lower limbs, right lower limb and left lower limb, and this black part is the greater trochanter. Okay, so proximal to distal spine, ASIS, GT and lower limb. Okay, so let us begin. So coronal plane deformities, what does that mean? It might be adduction deformity or abduction deformity. Okay, so first of all, what is deformity? Deformity means opposite movement is not possible. That is the basic crux line. Deformity means that opposite movement is not possible. So let's suppose the patient has 20 degree of adduction deformity. The patient has 20 degree of adduction deformity. What does that mean? It clearly means that abduction is not possible in this right hip. Abduction is not possible in this right hip. The patient has 20 degree of abduction deformity. What does that mean? That adduction is not possible in this patient. Am I making sense? Now we divide the deformities into two types. The first is fixed deformity. And the second is deformity with free movements. Okay, so we are going to understand this very clearly. Okay, so what is fixed deformity? Fixed deformity is that the lower limb is fixed exactly at that degree of deformity. So either opposite movement or ipsilateral movement, the same movement is not possible. Let me make it very clear. So let's suppose the patient has 20 degree of abduction deformity. Okay, so the lower limb is fixed in this deformity. So further abduction or adduction, either of them is not possible. 20 degree, let's suppose patient has 20 degree of adduction deformity. So further abduction or adduction, either of them is not possible. Okay, am I making sense? Now the second type of deformity is coronal deformity with free movements. Okay, so what does that mean? I'll explain you with the example. So the patient, let's suppose I say that this patient has 20 degree of adduction deformity with further 20 degree of free movements. Okay, so what does that mean? So first of all, 20 degree of adduction deformity. Okay, so the patient is having 20 degree of adduction deformity, and so abduction is not possible in both the types. Opposite movement is not possible. Now the patient has further 20 degree of free adduction. Okay, so let me make it further clear. Let's suppose this patient has 20 degree of abduction deformity with further free abduction of 30 degrees. Okay, let's suppose so what does that mean? So let's suppose the patient has 20 degree of abduction deformity. Okay, so adduction is not possible. Further the patient can go into 30 degree of abduction. Okay, so what is the range of movement? The range of movement is from 20 to 50. What is the range of movement? From 20 to 50. And if they ask how much is the adduction is not possible. Okay, so I hope I have made myself very clear. What is fixed deformity? Quickly. What is fixed deformity? Let's suppose this patient has 20 degree of adduction deformity. Okay. So now fixed deformity. What does fixed deformity mean? Abduction or adduction, either of them is not possible. The patient is having fixed 20 degree of adduction. Now the patient says, suppose the patient has 20 degree of adduction deformity with further 20 degree of free movement. So what is the range of movement? 20 to further 20, so 40. So this is the range of movement, but adduction is not possible. Am I making sense? I hope I am making sense. Okay. So that is the basic concept. That is the basic concept of fixed deformity and deformity with free movements. Okay. Now we are going to understand the compensation. How does the body compensate? Why is the compensation needed? So let's suppose the patient has 20 degree of abduction deformity. So now the patient wants to ambulate. Okay, so do you think in this position the patient would be able to ambulate? Both the lower limbs are not parallel. This lower limb would not be reaching the ground. It is not parallel. The plantigrade position of the foot is not possible. In 20 degree of abduction deformity, the patient needs to have bilateral plantigrade foot for ambulation. Okay, so how does the body compensate? The adduction is not possible. The patient is having 20 degree of abduction deformity, so that is what we discussed. So for making the foot go into the plantigrade position so that both the lower limbs are parallel and the patient can ambulate, anyhow the body has to adduct the lower limb. But at this junction, at the junction of femoral head and acetabulum, the pelvis, it is fixed. Adduction is not possible. So what does the body do? Mark my words. What does the body do? Body tries to shift the pelvis. So the anterior superior iliac spine goes downwards. So along with that, the lower limb goes in the foot goes into the plantigrade position, and as you can see, both the lower limbs are now parallel and the patient is able to ambulate. But what difference did it make? The difference it made was right anterior superior iliac spine, the right ASIS went downwards. Let me again repeat it. This is normal individual. This patient has 20 degree of abduction deformity. Patient is not able to ambulate because adduction is not possible. Patient has for putting the right foot in plantigrade position, anyhow adduction has to be done. So the compensatory mechanism is the pelvic shift. So right sided anterior superior iliac spine goes at the lower level to make this in the right foot in the plantigrade position. Okay, am I making sense? So what is happening indirectly? Right lower limb is getting lengthened. Okay, so this was the condition, and now right pelvis is going distally, lower, in the lower level. So right lower limb is getting lengthened. Okay, so that is why we say that in abduction deformities, whenever there is abduction deformities, the lower limb gets lengthened, and the corresponding angle so for every 10 degree of coronal plane deformities, the discrepancy is of 1 centimeter. Okay, so in this case let us discuss. There is 20 degree of abduction deformity. Okay, so to compensate this, right anterior superior iliac spine goes lower, and there is 20 degree of compensation. So what does that mean? That the right lower limb gets lengthened by 2 centimeters. Okay, so similarly we'll understand the adduction deformity. So let's suppose this patient has 20 degree of adduction deformity. Okay, so as you can see, both lower limbs are not parallel. Right foot won't be in plantigrade position. So to ambulate anyhow, abduction has to be done. But this junction is fixed. Further abduction is not possible. So how does the patient compensate? How does the body compensate? It compensates by the pelvic shift. So anterior superior iliac spine goes upwards. Anterior superior iliac spine goes upwards to make the right foot in plantigrade position. Am I making sense? Am I making sense? Okay, so let me repeat 20 degree of adduction deformity, 20 degree of adduction deformity, right foot in not in plantigrade position. To compensate, right ASIS goes superiorly, so because of this because of the junction being fixed, so both the lower limbs are now parallel. But what happens, as you can see during this movement, what happened was right pelvis went superiorly. So due to this, the right lower limb goes superiorly, so apparent shortening happens on the right side. Let me show it to you again. Right side at 20 degree adduction deformity. Now to compensate, what does the body do? ASI is going upwards. ASI is going upwards. So along with the ASI, the femur goes proximally. So there is apparent shortening. What happens is there is apparent shortening in adduction deformity. Similarly, to the measurement we discussed in abduction deformity, every 10 degree of coronal plane deformity corresponds to 1 centimeter of limb length discrepancy. So what happens here over here is 20 degree adduction deformity, and ASI is going superiorly with both lower limbs in parallel with 20 degrees. So 2 centimeter shortening happens. So this is the compensation. So I repeat, in abduction deformity, compensation is by ASI is going downwards. Okay, now, and right lower limb becoming lengthened. And in adduction deformity, to make the right foot in plantigrade position, right anterior superior iliac spine goes upwards with right lower limb becoming shortened. Okay, and every 10 degree corresponds to 1 centimeter of limb length discrepancy. Am I making sense? So remember this point, put it in your mind, let it cross your blood-brain barrier. In abduction deformity, what happens is ipsilateral ASIS going downwards with lengthening of the limb. And in adduction deformity, ipsilateral anterior superior iliac spine goes upwards with shortening of the lower limb. And every 10 degree, I repeat, corresponds to 1 centimeter of limb length discrepancy. Okay, so that was the whole concept, that was the whole crux. Okay, so now what we are going to discuss is how to determine the coronal plane deformities. Because the patient, whenever the patient presents, the patient presents with both lower limb parallel to each other. So already the compensation has happened. So we need to understand what has compensated, how much it has compensated, to find the actual coronal plane deformity. Okay, so that is Perkins method. Perkins method is just the retrograde concept of what we understood till now. Okay, so let me give you an example. Suppose the patient, let's suppose this is the position in which the patient presents. And both the lower limbs are parallel to each other. Okay, both the lower limbs are parallel to each other. Now you have been asked to measure if there is any coronal plane deformity. So first we are going to discuss about the Perkins method for fixed coronal plane deformity. Perkins method is different for fixed coronal plane deformities and deformities with free movements. Okay, so let us suppose this is the condition of patient in which it is presenting to you. Okay, and you have been asked to check whether there is any coronal plane deformity. Okay, so what the first thing do you see is there is right anterior superior iliac spine has gone at the lower position. Right ASIS is lower as compared to left side. Okay, but both the lower limbs are parallel. So yes, there is some compensation that has happened to keep both the lower limbs parallel to each other and in the plantigrade position of the foot. Okay, so what would have happened? You just imagine. So how do we understand the simple maneuver in cases of fixed deformities? The simple maneuver of Perkins method is to put both the anterior superior iliac spine at the same level. What is that called? Both the ASIs at the same level. What is that called? It is called squaring of pelvis. It is called squaring of pelvis. So what do we do in this condition? As soon as we keep both the anterior superior iliac spine at the same level, as you can see, the right lower limb is going in abduction. So always that is the thumb rule we understood. In abduction deformity, ASIS goes lower. In adduction deformities, ASIS goes higher. Okay. So the first maneuver, the first and most important maneuver is simple: square the pelvis and see for the orientation. So this was the, I repeat, this was the condition of the patient presenting. Okay, and you have been asked to measure the coronal plane deformity. Okay, so you see that right ASIS is lower. So you suspect that this might be a abduction deformity of the right side or adduction deformity of the left side. Either of them could be there, but let's suppose right hip is the pathological hip. So okay, so this is how the patient has presented. Right hip is the pathological hip. So what do you suspect? Right anterior superior iliac spine is at a lower level. What do you suspect? You suspect that it would be a abduction deformity of the right hip. So the simple maneuver, you square the pelvis by abducting the lower limb. So you do the movement of the deformity. Am I making sense? Very simple. Right ASI is lower level, you are suspecting a abduction deformity. So you abduct the lower limb, same side movement you do. So you abduct the lower limb to square the pelvis and measure the angle with goniometer. Of the vertical axis with the lower limb axis. Okay, similarly, let's suppose the right-sided anterior superior iliac spine is at the higher level. This is how the patient has presented. Right hip is the pathological hip. You have been asked to find if there is any coronal plane deformity. What do you see? Right ASI is at the higher level. What are you suspecting? You are suspecting a adduction deformity. So how do you square the pelvis? You square the pelvis by adducting the lower limb. And as soon as both the anterior superior iliac spine are at the same level, that is when you measure the vertical axis with the adduction angle, with the angle of the lower limb. So that is the adduction deformity. So that is how you measure the fixed deformities. That is how you understand the fixed deformities, coronal plane deformities, by Perkins method. Okay, so I repeat the Perkins method clearly, very quickly. So first thing you look is anterior superior iliac spine, whether it is at a lower level or higher level. If it is at a lower level, what are you suspecting? You are suspecting a abduction deformity. So what do? You abduct the hip until both the anterior superior iliac spine are at the same level. Once the ASIs are at the same level, the pelvis is squared. You measure the vertical axis with the angle with the axis of lower limb. That is the abduction deformity. Similarly, if the anterior superior iliac spine is lying at the higher level, so what are you suspecting? You are suspecting a adduction deformity. So what do you do? You adduct the lower limb to compensate the shift of anterior superior iliac spine. Once the ASIs are at the same level, you measure the vertical axis with the lower limb axis, and that is how you measure the coronal plane deformity for fixed deformities by Perkins method. Okay, so this was the Perkins method for fixed coronal plane deformity. Now we are going to understand the Perkins method for coronal plane deformity with free movements. Okay, so this is the most interesting and exciting part of the video. Okay. So before I begin, let us again revise what was free movements. Okay, so let's suppose the patient has 20 degree of abduction deformity. So what does that mean? 20 degree of abduction deformity with further 20 degree of free movements. Okay, so what does that mean? That this is the position of 20 degree abduction. Adduction is not possible, but further 20 degree abduction is possible. So the range of motion is between 20 to 40. Okay, 20 to 40. So this is the condition of the patient. And how does it compensate? How does the body compensate? By right anterior superior iliac spine going at the lower level to make the plantigrade position. Okay. So now this is how the patient has presented to you, and you have been told to measure the coronal plane deformity. and right hip is the pathological hip. Okay. So now let us understand. We will follow the basics of Perkins method. Right anterior superior iliac spine is at the lower level. What am I suspecting? I am suspecting a abduction deformity. So what do? You abduct the lower limb. You abduct the lower limb till the pelvis is squared. But sometimes while measuring, you can also go up to this level with no movements of the pelvis. You can also go up to this level with no movements of pelvis, because 20 to 40 was free abduction. 20 to 40 was free abduction. I'll repeat. Okay. So let's suppose right ASIS is at the lower level. Right ASIS is the lower level. You see ASIS, what are you suspecting? Abduction deformity. Following the Perkins method, you abduct the lower limb till the pelvis is squared. But by mistake, you excessively abducted it. Because this is the free movement. It is not a fixed deformity like we discussed prior. Fixed deformities, after going to 20-degree angle, if you go in further abduction, the ASIS will move. But in this, there is free movement. So this is over abduction. So you can estimate, by mistake you can say that okay, 40 degrees is the abduction deformity, but that is what we don't want. So how will we know? So after abducting, we will again check by adducting. To look for the anterior superior iliac spine going downwards. Okay, so let me repeat. Right ASIS is at the lower level. Okay. Now following the Perkins, you square the pelvis, but by mistake you have gone up to 40 degree of abduction. So you might be thinking, 40 degree is the abduction deformity. But to cross check, so you again adduct the lower limb. So this 20 degree ASIS is not moving. Now it has reached the actual abduction deformity, and on further adducting, the ASIS moves. So you stop. So this is the actual abduction deformity. Okay, am I making sense? So what do you do in Perkins method? Look at the ASIS. If it is at the higher level, it is adduction deformity, or if it is a lower level, then it is abduction deformity. You follow the principle. If it is abduction deformity you are suspecting, you abduct the lower limb. Till the pelvis is squared. But to check whether you have over abducted and overestimated the deformity, you again adduct till the time ASIS goes at the lower level, and that is when you know the actual abduction deformity. Okay, so we'll understand this concept with adduction deformity again. Okay, so let's suppose this patient has 20 degree of adduction deformity with further 20 degree of free adduction. Okay, so that is, let's suppose this is how the patient is presenting to you. So we'll follow the Perkins method. Right ASIS at the higher level. What are you suspecting? Adduction deformity. So you adduct, you do the same movement as the deformity to square the pelvis. Okay, so while squaring the pelvis, you adduct the lower limb, but you have over adducted. So 20 to 40 was free adduction. So how will you know whether you have over adducted or that is the actual adduction deformity? So you do the opposite movement. You abduct till further 20 degrees and then when it has reached the actual adduction deformity, if you further abduct, the ASIS will move. So you stop at this moment. So you know that this is the actual adduction deformity. Okay, am I making sense? So quickly I'll repeat the concept. Let's take a case. So let's suppose right anterior superior iliac spine is at a lower level. Right hip is the pathological hip. You have been asked to estimate the coronal plane deformity by Perkins method. Okay, what will you do? Okay, so our purpose is we look at ASIS, right ASIS at the lower level. What are you suspecting? You are suspecting a abduction deformity. So what do? You abduct the lower limb. So ASIS moves higher and the pelvis is squared. But to know whether you have over abducted, over analyzed, you again adduct So this is free abduction you are compensating till the, and now this is the actual abduction deformity, and on further adducting the ASIS goes lower, so that is where you stop, and this is the ideal abduction deformity. Okay, am I making sense? Let's take another example. Right ASIS at the higher level. Right ASIS at the higher level. What are you suspecting? Your right hip is the pathological hip. You are suspecting a adduction deformity over the right side. So what do you do? You adduct the lower limb. So as soon as you adduct the lower limb, there is squaring of the pelvis, but by mistake you over adducted. So to know the actual deformity, you cross check, you confirm by abducting. So you are abducting, ASIS is not moving, and this point the ASIS again moves, so you stop, and this is the actual adduction deformity. Okay, so it is very interesting. Keep practicing about this, you will get to know, understand. Okay. So the concept of compensation and Perkins method are exactly the same. The Perkins method is very interesting. Look at ASIS. If it is lower, you are suspecting abduction deformity. If it is higher, you are suspecting adduction deformity. You move the lower limb in the direction of the deformity till the time is pelvis is squared. Now to check whether you have overanalyzed, you do the opposite movement. Till the ASIS starts moving, and that is when you stop to know the true coronal plane deformity. Okay, so this was all about the Perkins method. So now last part is one of the very interesting parts, is the trunk and scoliotic compensation. Okay, so now I hope the distal part from pelvis to lower limb, that is lengthening, ASIS going up or down, all these things you have understood. Okay. So now, how does the scoliotic compensation occurs? Okay, by the trunk shift or trunk tilt. Okay, so what happens? So to understand the scoliotic correction, we'll take directly the example. Okay, so let's suppose the patient has abduction deformity. Okay, so to make the right foot in plantigrade position, the compensation is right ASIS going at the lower level. Now proximally if you see what has happened, trunk was straight, it has tilted due to the pelvic tilt. The right pelvis has gone at the lower level, which has caused the trunk to shift towards the right side. Now you can't stay like this, the body can't keep the trunk like this. So how does the body compensate? Can you imagine how does the body compensate? The body compensates by shifting the trunk towards the left side. So how does the body do? The body does scoliotic correction. So what happens is the convex side goes to the ipsilateral side in abduction deformity. Let me explain it to you once again. Okay, so let's suppose the patient has abduction deformity. The compensation is by right ASIS going at the lower level, but the trunk has shifted to right side. So the compensation to make the trunk lie straight is by scoliotic correction. So always in abduction deformity, the convexity lies towards the affected side. The convexity of the scoliotic correction lies towards the affected side, so that this is the head, so that the head lies centralized. Similarly, we'll understand the scoliotic correction in adduction deformity. So let's suppose this patient has adduction deformity. So how does the hip compensate? The hip compensate by right ASIS going at the superior position. What does it cause? It causes the trunk going towards the left side. So now we want the head to be well centralized. So how does the body compensate? The body compensates by scoliotic correction. So as you can see, the concave border faces the pathological side. So in adduction deformity, The scoliosis, the scolotic correction is concave border being at the affected side. Let me repeat quickly. If the patient has abduction deformity, right ASIS is going at the lower level, and as a compensation, the trunk goes into the right side. So as a compensation, what happens is there is scoliotic correction with the convex border towards the affected side. Similarly, if there is adduction deformity, how does the body compensate? By right ASIS going superiorly. The trunk goes towards the left side. So to make the head well centralized, there is the scoliotic correction which forms the concave border towards the affected side. Okay, so simple to remember is in abduction deformity, the scoliotic correction is such that the convex border is on the affected side, while in adduction deformity, the scoliotic correction is such that the concave border is on the affected side. Okay, so this was all about the very interesting and exciting concept of coronal plane deformities of the hip. So you need to practice it multiple times to enjoy this process and the concept of coronal plane deformities. I hope you found it useful. This was Dr. Mihir Tejura signing off with coronal plane hip deformities simplified for you. Thank you so much, guys. I would love to get your feedback in the comment section in the social media page. Stay tuned for further tutorials on orthopedics simplified for you. Thank you so much, guys.